Good morning, everybody. Thank you very much for the invitation. It's a privilege to be here in Switzerland. It's a wonderful day for you guys where it's raining. I wish to talk about the philosophical evaluation of different presbyopia methods, with apologies to true philosophers. It's about presbyopia and its influence on ophthalmologists and patients. And that is my name. As you can see, I have no financial interest in any product. In fact, it costs me a lot of money. When asked to send 3 topics on presbyopia, I included one topic which I was sure would be rejected. It's to save me some working time. And this is that topic. So this is not a totally scientific talk, although the meeting is scientific. This is rather my personal, if somewhat philosophic opinion about presbyopia. Presbyopia treatment is at the same time a science, an art, an exercise in psychology, an exciting new business, a risky venture. It's gratifying and it's at the same time terrifying. Treating presbyopia may be either very easy or very difficult. Prescribing reading glasses is easy. My assistant can do it. Treating the cornea, all the lens to cure presbyopia, is a complex challenge. It's fraught with danger, complications and side effects. Pearls and pitfalls of presbyopia surgery definitely have more pitfalls than pearls. Exactly the same result may make one patient happy and the next patient extremely unhappy. The problem with presbyopia is that there is no cure. Treatments abound and claims of successes are made, but at this moment in time there is no single cure for presbyopia. Firstly, I have to mention that I am presbyopic. Here they are. So I know the problem. It's really a pain. Everywhere you go, you are invariably confronted with the situation of looking at something close to you. Your mobile phone and SMSs become a threat. The menu in the restaurant is a daunting challenge. Your children's pictures, the boarding time on an airline boarding pass, the amount on the credit card slip, the name tags next to the food at the buffet, the inscription on the shampoo or conditioner bottle in a hotel. I mean, imagine washing your hair with a conditioner. The numbers on the golf scorecard are all examples of the impact on presbyopia on our daily living. And for the ladies, one of the mysteries of presbyopia for me is how a presbyopic woman can manage to do her eye makeup. There are things in ophthalmology men just do not understand. All the time presbyopia irritates you at home, at work, at play, on holiday, everywhere, and dozens of times per day. Another comment on the frustrations. If you listen carefully, you will realize that our presbyopic frustrations are intimately related to our modern way of living. It is concerned with reading print and computers, menus and traveling tickets, cell phones and TV remote controls. It has nothing to do with relationships, love, happiness, compassion, spirituality or wisdom. Not even with eating, drinking, dancing, singing, having a party or playing sport. So what is presbyopia? The age-related, gradual and progressive deterioration of the ability of the lens and ciliary body to accommodate to attain near vision. It occurs in every eye which has its own crystalline lens, regardless of any other condition or pathology of the eye. Presbyopia as a disease. In geriatrics they say that aging is normal. It is not a disease. Now I do not agree with that. Aging later in life becomes degeneration. And degeneration is one of the well-known causes of disease. In my personal opinion, presbyopia is a degenerative disease. And any disease should be treated if at all possible. The etiology of presbyopia, as we know, it's age-related. You have lenticular changes, ciliary muscle changes, and then it's hyperopia-related. Hyperopia leads to early presbyopic symptoms. The influence of myopia, as we know, myopia delays the onset of presbyopic symptoms. Another word about etiology. Claims have been made that 1,000 milligram vitamin C per day delays presbyopia. Fitness. Apparently fitness can also delay the onset of presbyopia. And then UV exposure. Farmers and outdoor workers develop more and earlier lens sclerosis, which causes earlier presbyopia. Diagnosis, very easy, mainly history, age plus symptoms. The patient will come in and say to you, I cannot see. That's not good enough. You must look at the patient, see that he's 50 years old, and then ask him, do you mean you cannot see far or near? And then you do the distance and near visions, and you can use the Jaeger or Snellen measuring methods. And here is a chart comparing Jaeger to Snellen. If you know it, you know it, and if you do not know it, you do not know it. But if you look at J2, you'll see it is equal to 6.9 or 0.67 vision. And this brings us to the next point, and that is, what does near vision in everyday life have to be? If you want to read the telephone directory, you must be able to see J2. SMS writing varies between J1 and J3. The computer font at 10 at 40 centimeters is about J2 to J3. Normal newspaper print is about J3 to 5. And the very important factor is contrast. If the contrast is good, you can see better. And if a patient can read J2, he should be about 95% independent of spectacles, in adequate contrast. Treatment options. We all know that there are conservative and surgical treatment, and spectacles, contact lenses are very common. Then you can do monovision with contact lenses, monovision with surgery, and corneal or lens surgery. A few words about conservative treatment. Spectacles are easy. Multifocals, that's a whole subject for optometrists, and multifocals are getting very good. And another innovation is the customized room distance multifocals with an up to 3 meter radius. Excellent vision for the professional in the office. Contact lenses. Multifocal contact lenses provide either good near vision or good distance vision. That's what my optometric friends tell me. Multifocal contact lenses are only successful in the absence of significant astigmatism, less than 1 diopter. Then you can have a patient with monovision with contact lenses, for which you do a plus 175 contact lens in the non-dominant eye, and it doesn't work for men. Very seldom for men. Contact lenses are reversible and quite safe, and as you can see, there are also a possibility of complications. Now, let's move on to surgery. My personal comment now is that this talk is not about technical presbyopia surgery and will not discuss detailed surgical procedures. It's about the different treatment options for presbyopia and about the complexities of patient selection. Most of all, it attempts to reveal the fact that the treatment of presbyopia is still a challenge to refractive surgeons. Presbyopia has not been conquered. Let's look at surgery, and if you go with me through the list, you'll see how many options there are. And that is just the point. There are too many options. Surgery to create monovision, LASIK or ASA, making one eye myopic and the other eye plano. Lens surgery, implanting one eye with monofocal IOL for near vision and the other eye with a monofocal IOL for distance vision. That's a perfectly reasonable option. And look at all the others. Surgery, atypical monovision with unilateral multifocal surgery. One eye presby-LASIK and other eye emmetropic. Or one eye femtech intracore, about which I will speak later, and the other eye emmetropic. One eye multifocal IOL and the other eye emmetropic without touching the eye. Or you can put a multifocal lens in the one eye and you can put a monofocal lens in the other eye. Or you may have a patient who had it before and do a multifocal in the second eye. Surgery to create monovision. Basically, you can do any surgery to create good near vision in one eye and create monovision, provided you select the right patient. That is absolutely crucial. Then we have other treatment options. CK, holmium laser gave some good results. Corneal inlays, presby LASIK, intracore femtech presbyopia treatment. Bilateral treatment options. Lens surgery for presbyopia where the patient does not have a cataract. Prelex with the different lenses such as Restore, Technus, Resume, Aquilisa. Or clear lens extraction with accommodating lenses such as the crystal lens or the tetraflex lens. And if the patient has a cataract, it's a bit easier, but we can use the same lenses as mentioned before. My next talk is about the Restore lens, but the others are perfectly good options. And then you can also use clear lens cataract extraction with accommodating IOLs. And there are other options. Lens surgery for presbyopia in a pseudophakic eye with a monofocal IOL. So the patient had been operated, has a monofocal IOL in, wants a multifocal vision. And Rainer makes a sulcoflex multifocal pseudophakic supplementary IOL which goes in the sulcus and which works quite well. Corneal versus lens treatment. My personal opinion is that for presbyopia, lens surgery is inherently better than corneal surgery because the basic problem is in the lens. I predict that treatment of the cornea will only be transitional in nature and will not stand the test of time. Eventually, in future, it will be replaced by lens treatments. So we get to patient selection. Why is patient selection so important? Because there is no single treatment that always works. So individualized patient treatment must be selected for every patient. So informing the patient, it's a part of the patient selection. Communication is a challenge and misunderstanding common. You have to explain the whole thing to the patient yourself. During this explanation, you observe and study the patient's response and evaluate the patient's personality. If you let an assistant do this, they may make mistakes and you will pay the penalty. Good information helps the patient to make a decision. Nobody can predict the patient's response to surgery, not even the patient himself. In fact, you can probably predict the patient's response better than what the patient can predict it. Information is supposed to prevent litigation, and the more information, the safer the surgeon. Informing the patient, the more sophisticated the society, the more emphasis is placed on information. Some patients just come to you and say, I don't want information, I trust your decision, doctor. Now that's nice, but it also puts a burden on the doctor to make the right decision. The more information, the more fear can be created. Remember to underpromise and overdeliver, and don't create too high expectations. Monovision patients, it's easy to explain. You should do a contact lens trial, and you mustn't do it for very active people. One of my patients of age 68 years is a super bike rider, and he said his vitreous floater in his one eye irritate him when he does more than 300 kilometers an hour with a super bike. So you must listen to what the patient does. Occupation and activities. Night driving is a problem, and then is it an electrician or a motor mechanic? Not for bird watchers, astronomers, optical engineers or photographers. Perfectionist. If a patient says, I hate my glasses because I cannot see, you must not operate him, but that's an optical complaint. If you are difficult to please, you are difficult to please. Good candidates for surgery. Easygoing, low-key type. Patient says, I hate my glasses because they are always lost. This is an excellent candidate for surgery because he doesn't like handling the gadget that complicates his life. Complicating factors. Everything surrounding the treated cornea or multifocal IOL must be perfect. The patients must understand that. Contrast sensitivity is important. And yeah, I can go through all the slides quickly, but I would like to just move on to the philosophical part. And we all know that small children only need near vision to get to go to the world, to get to know the world close to them. As they grow up, their horizons become wider and they retain their near vision. As young adults, they have to use near vision and far vision. Then as they get older, they achieve wisdom. And you must realize that as we get older, we are maybe not supposed to see near as well as we thought, because perhaps we should come to a point where we sit on the mountain and gaze into the distance, contemplating thoughts of wisdom instead of being hunched over our laptops trying to compete with the younger generation. And besides, you won't see the wrinkles on your wife's face. So perhaps presbyopia is not such a bad thing after all. Thank you.